us today here at Healthcare Providers Transformation
My
Assembly.
pleasure.
So we'll jump straight into these questions, and I'll first ask you, so in your opinion and your role, how is digital technology impacting the business of healthcare?
Well, profoundly, obviously. It's difficult to really summarize into to a one or two different short answers, because the profound impact is broad and it's deep. The areas that I guess we see probably the most consistency within our organization is we've been trying to do decision support in our medical record system for 40 years. And we're seeing the technology allowing us to do that more effectively than ever before. That is capable of improving consistency and providing high quality outcomes, usually with lower costs and lower utilization rates. So a really good example of that is sepsis, one of the leading killers in hospital care in the United States. And being able to very rapidly diagnose sepsis and then treat sepsis has been a huge challenge. Bringing digital capabilities to that process really in two ways: being able to identify it more quickly, run through, if you will, a checklist of things to look for, has been a step in the right direction. But then perhaps even more importantly is creating a consistent pathway for treating people that have been diagnosed with sepsis, usually beginning in the emergency room. We've built that into about a 9-step process that can be deviated from if people are, people are different individually. But to generally follow that process, and that tends to lead to an accurate diagnosis of whether there's sepsis. And if there is, then we have been able to automate the transfer to an intensive care unit, where care continues also along a pathway, creating enormous benefits, with the result that the number of people dying of sepsis has dropped by about 3/4.
Wow,
over about 5-year periods. So yeah, really remarkable outcomes. And oh, by the way, the costs have gone down by doing that. So
win-win for everyone, isn't
exactly.
it? So actually, leading to that sort of thing of identifying sepsis earlier, has the physician culture shifted because of this sort of digital transformation, and have physicians responded positively to these initiatives?
I think the answer to the first question is yes, it has impacted change. I'm not sure most of us realize how profoundly we're impacted by technology. I mean, whether that's a physician or whether it's somebody working with their cell phone, I think that if we look back, it's very difficult to remember what it was like before we essentially were tethered to and attached to our technology. So I think that physicians probably aren't aware of how profoundly they have been impacted by that. Now, the second question is essentially, do they appreciate that? And I think the answer is, by and large, no. In the same way that I think many of us have technology that we become dependent upon, and the irritations associated with that technology are often at the forefront of our minds.
Very true.
But I think were that to be taken away from us, and in the case of our physicians, were that to be removed from them, they would recognize quickly and profoundly how much of a loss it would be in their practice and in their lives. So it's I think that the degree of impact is underestimated, and the degree of benefit is also underestimated.
So actually, one of the things that we talked about is about the challenges behind launching digital programs. That's a lot of what the conversations are here today, is about how to tackle those challenges.
Right.
So what has been the biggest challenges in your career rolling out these sort of digital or new initiatives?
I think the biggest challenges are not associated with digital per se. The biggest challenges are associated with the fact that implementing digital means changing the way that we actually work. Sometimes it means changing the way that we think. And so I think the biggest challenges are associated with that. We see that all the time. Certainly anybody who's installed a new EMR sees the profound impact that it has. And by and large, when you talk to people about the challenges associated with it, they will describe, whether it's Epic or Cerner or whatever, putting this in has been the biggest challenge ever, and they will impute to technology some of the challenges which are really workflow changes.
Okay.
And the workflow changes in some instances are beneficial and would have been good even if they'd been done in a pre-digital world, if you will. In some cases, they're irritating and have to be forced by the technology. So it's a hodgepodge of those things.
So what advice would you have for healthcare leaders who are pushing these initiatives through and potentially hitting those roadblocks?
The thing that I think is probably the most profound and what's been probably most beneficial for us is seeing that it actually changes the outcomes in meaningful and beneficial ways. So we mentioned sepsis, but that's just one of probably 80 or so areas that we have implemented. And in virtually every one of those, quality has gone up, costs have gone down. And if physicians and other caregivers are given the opportunity to say, here's a before, here's an after, let's take a look at the outcomes and see how they are. Suddenly they go, oh, okay, well, it is a sacrifice, it's a change for me, but I can see why it would happen. Quick other example. In installing tele-ICU over the last number of years, we have seen fairly significant improvements in clinical quality of care. And there was a worry on many people's part, understandably, that, wait a second, if the experts are now at a distance, are we going to have the same level of patient coordination? But the way that the implementation has worked out is you've got lots of really capable people on the front line, hands-on, capable of working with the patient, but you also have somebody with deep clinical knowledge in the very specific area that a given patient might need that's there to provide backup. And the connection of those two things tends to result in better clinical outcomes and oftentimes shorter stays in the ICU and other things that result in lower overall costs. So it's being able to see the before and after, when people would say, no, would you really want to go back and do it that way? The good old days weren't necessarily really that great. So.
I mean, that's a perfect answer, leading us straight on to talking about how that Intermountain has won several awards for its telehealth initiatives. And you recently announced that you've gone live on American Well Exchange, a leading telehealth company. So your tele-ICU is actually slightly different use of telehealth. I think most people think of it about physician to patient being remote, that kind of thing. So it's an interesting different use case. But what was it about telehealth that really stood out to you guys?
Your point is a good one. The phrase telehealth is a little bit disconcerting because it can mean so many different things. So, and I'm going to miss some of maybe even some very important ones, but we have a number of different ones. As you mentioned, the American Well approach is essentially working with people from their homes. For a patient that's home, not feeling well, the last thing that they want to do is to get in their car and go to their physician's office or an urgent care setting, or worst yet, go to the hospital emergency room where they're going to spend lots and lots of money potentially and simply be told, yep, here you need an antibiotic, or there's nothing we can do, go home and rest for 48 hours and you'll feel better. And so being able to do that from home, we think, is obviously a huge benefit, not only to the person who feels lousy and doesn't want to go out, but presuming that they have a communicable disease, do you really want those persons to go sit in a waiting room or be seen by 5 other human beings that might be able to pick up the same disease they've got? So lots of reasons for that end, but there are other components of telehealth too. Occupational medicine is one that we've been doing now for some time, which is really beneficial. People who can get care at their work site, treatment remotely. for mild work site injuries or illnesses, and the question is, does this person need to go home? Do they need to go to a clinic to be seen? Well, with telehealth, you can answer that question with 99% certainty. No, they're fine. They can stay working if they feel up to it. No, they should quit and go home and rest for 2 days. No, they should come into the urgent care center. The cut that they have looks like it requires stitches, doesn't, things like there are any number of things where you can make people's lives considerably easier and the cost considerably lower. So there's that one. I also mentioned ICU. A couple of others that we've had really, I think some interesting results from were related to augmentation in the emergency room. So consultations for mental health. Always difficult when people come to the emergency room with a potential mental health issue to know whether, whether the primary cause that brought them there is their mental health or something else. They may come in complaining of abdominal pain or something else, and being able to tease out the mental health component is critical. So having that, a highly capable backup facility there is really good. Another one that works in much the same way is telestroke and teleservices related to coronary artery disease, blockage, heart attack, and being able to have the most capable people in the West be able to see this person as they present in a small rural hospital can be enormously beneficial, so that they don't get, something doesn't get missed and they get undertreated, but almost equally as important that they don't get overtreated, because some of the treatments, the aggressive treatments that we do for people, whether it's with mental health or stroke or whatever, if you diagnose it incorrectly and provide heroic treatment, you can kill them. So being able to have the most capable backup resources there are terrific.
That's so interesting, because in all honesty, when I was looking at telehealth and things, I'm a marketer by trade, not necessarily in healthcare. And I honestly was mostly talking about the whole, patients who live remotely, don't have to go in and see their physicians. There's so much more to it. And it's really, really
There's
interesting.
There's a lot to it.
Really interesting. So, talk about telehealth, things like that. I imagine that gives you a whole expanse of data that you can use. The digital revolution helps you get data and think data.
Which is huge.
So how, I've seen a couple of interviews that you've talked about data before and moving towards being data driven. How do you think that's going to improve clinical quality as well?
Well, data is everything. So just as if you've got time for a short story, let me give you one.
Oh, go for it. No, absolutely.
So many years ago, we were working on a process to identify the best treatment for acute respiratory distress syndrome, which is also called ARDS, ARDS. And at the time, ARDS was 90% fatal. Virtually everybody who got it died. And so we were one of the 4 largest ARDS treatment centers in the country, because our mortality rate was only 85% or something. More people survived there, but it was still horrendous. And so a group of our cardiologists and pulmonologists got together and said, what if we were to put people, and by the way, what ARDS does, it means you essentially aren't able to assimilate oxygen through your lungs. Your lungs are incapable of transferring oxygen very effectively, and they shut down. So one of the approaches, the approach that had been historically made, is that people were just put on a mechanical ventilator, and that was, and then they tried to make sure that everything that was going wrong with their body didn't kill them in the meantime. So one of the thoughts was, well, maybe we should put people on a heart-lung bypass machine, which actually oxygenates blood with outside of the lungs. And so as they put this together, now this is where the data part comes in, the lead pulmonologist, a doc by the name of Alan Morris, said, if we want to make this a really good study, what we need to do is to have a really good control group. And so what I want to do is to computerize, mind you, this is back in the 80s, We need to computerize the care that we're providing for people so that we can isolate what's different between the heart-lung bypass machine and those who are being treated traditionally on a ventilator. And so that we don't introduce a lot of other variables that confound our experiment. So what he had the folks in the ICU doing was making sure that they documented exactly what they were doing for each patient and then created a care pathway, if you will. And he said, we can always deviate from it, always do what's right for the patient, but if you deviate from the care pathway, let's document it so that we can identify where we need to change our care pathway to be the very best care. Now, the interesting thing that happened is they were just trying to stabilize the process before they decided to try the heart-lung bypass machine. And mortality rate dropped from nearly 90% down to below 60%. And they hadn't done anything. Well, they really had. I mean, they thought, wait a second, we didn't do anything. All we were doing is what we always did. But what they were really doing is they were stabilizing the process. Okay. And that gave huge data, because what they had now is data that said, oh, okay, if we change the creatinine level, here's what happens. If we chase the sodium levels in the blood, here's what happens. If we raise the oxygen level in the blood, here's what happens. And all of those data points then allowed the patient and future patients to be viewed in a very different way than just here's my gut feel of what we ought to do for this patient given what I'm seeing, because these are vast amounts of very complex interactions there. You change one thing in order to improve a lab score, you may do something that totally destroys something else. It damages liver function by trying to increase kidney function, et cetera, et cetera. So having that kind of data is huge. The other mechanism that we think is enormous, people talk about it as big data, which is a buzzword that few understand.
Really know
right?
What's going on with it
right.
yet?
but the real answer, I think, is if you have population-wide data that really looks for if a person in the population has these characteristics, here's how they're likely to respond to this treatment. Those kind of things are enormous. And again, we're in a fortunate situation where, because I think we now have had electronic medical records for longer than any other organization in the United States, and have been gathering data throughout that time. It's longitudinal. We have data on people back to the late 1970s, all on an automated basis. And we often now, given our relatively modest geographic footprint, have information about multiple people from families, so you can tie familial relations together to look for consistency of diseases. And now, as we're adding genomic information to individuals in that, you can look at all kinds of correlations that allow us to be very thoughtful about saying this drug is very effective, but only if people have the following characteristics. Those might be characteristics about their demographics, they might be genomic, they might be related to the illness type that they have. Yeah. So any number of things. So yeah, as you say, having data that is machine readable and organizable and crunchable is incredibly valuable.
It's so interesting, because I was actually asking someone who works in retail a similar question about the power of data. And she said in a lot of industries we're data rich and knowledge poor. And then we were talking about healthcare, and actually the knowledge that you guys have put into use for the data is kind of a case study for other industries on how to better use big data, to use the buzzword.
Maybe sometimes, yeah. There's lots we don't do very well yet.
So can you talk us through the journey at Intermountain when you moved away from your fee-for-service payment model, which you were spearheading that initiative?
Well, we've done that, and I think a lot of people sort of assume that that's something that's happened in the last few years and related oftentimes to the Affordable Care Act. But in fact, it really isn't. That's something that for us goes back 35 years.
Wow.
And it started in 1982 when we started our own insurance plan. And over time, I think a number of organizations started insurance plans but found them extremely difficult to do, and we can relate, it is difficult to do. But we stuck with that, and for the last decade or so, we've been the largest insurer in the state of Utah. And the fact that we have been thinking about care from the perspective of premium cost, I think has made us think differently. Something that happened that was really fairly profound, this was years and years and years ago, this was in probably 1987, something like that anyway. And a number of our senior leadership folks, our CEO, our CFO, and a number of others were in a situation where they said, we'd really like to help our community. They know us, Intermountain Healthcare, they know our hospitals, they know our physicians. They don't necessarily know this insurance company that we started, and we'd like to have them understand that this whole company stands behind the insurance product, and so that'll make it more, it's kind of a marketing thing. But something really different than just marketing happened. So we had these senior leaders go out on sales calls, if you will, to talk to potential purchasers of our insurance plan. And what they got was something really profound. They talked to people, mostly small business owners or medium-sized business owners, who would say things like, my insurance premiums went up 14% last year, and in order to pay that, I had to let 17 people go. Or
wow.
I had to lower I wasn't able to give anybody salary increases last year because I had to use it to pay for health insurance premiums. Suddenly, health costs became profoundly personal. And we started to think about it way differently. It wasn't just, well, our prices go up, that's fine, we pass them off to some insurance company, and heaven knows insurance companies make lots of money, so who cares, right? So being able to visualize that this has real impacts on real people. There are people losing their jobs or not getting their pay increases or not being able to, be able to have a nice Christmas for their families, or things that were really personal, made the crusade of trying to bring value to healthcare something that was, I think, more profoundly important to us than it had been before, and I hope that has stuck with us. I think it's hugely important.
I definitely think so. When I was obviously researching yourself in Intermountain, I came across many articles where you guys really do have a reputation for delivering high quality care at a lower, more average, more valuable cost.
Kind of what we hope we can do.
Well, from what I read, you guys are pulling it off.
No, that's
certainly.
nice of you.
So, I know we haven't been at the event for very long. Obviously, we've been for a couple of hours so far, but we do always try to ask our attendees just a couple of questions about it.
Okay.
So, when you were, talking about whether or not you want to come to the event, what did you see as the biggest benefit as coming to our event today?
Actually, I will just be candid and say I didn't quite know what to expect. So I was.
That's always nice.
Just
expectations. That means we can surprise you.
Yeah, exactly. So coming to see how things were, and I did notice that there were some of my colleagues who I have great respect for who would be here. So that's always helpful. And so far so good.
Excellent, good. So you have only been here for a little while, but we of course like to know that our events stand out in comparison to others. Was there anything that you've spotted so far that made you think that this was slightly better than something you've attended before? I've only been here for a couple of hours.
Having been here to exactly one session so far. Again, I think it would relate to the people who are around the table, some of whom I knew and some of whom I knew by reputation. Who I think led to a good discussion that was definitely worthwhile.
Awesome, that's what we like to hear. Thank you so much, Greg.
Certainly.
You are an absolute pro at this, you really are. So good.